Someone said hi to you, Dr. Raymond, on the chat box.
Yeah.
Somebody you know? Is it?
I think so.
I think it's 3 now. Is it okay if I start?
Yeah, I'm okay.
Okay. Okay. So, a very good evening to everyone in attendance. Welcome to the third week of the Respiratory Medicine Seminar, and the topic for today is biopsy approaches in lung cancer. So, we're very privileged to have with us today our chairperson, Dr. Raymond Das Maria Das, who is currently based in Hospital Tuanku Jaafar, Seremban. And our speaker for today, Dr. Hema Yamini, she's currently a respiratory physician and head of department in Queen Elizabeth Hospital, Sabah. So a little bit of introduction about Dr. Raymond. He obtained his MBBS from the University of Karachi, Pakistan, and then obtained his MRCP Ireland in 2012. He then proceeded to do his fellowship in respiratory training under the Ministry of Health Malaysia and did a year of fellowship in Perth in Sir Charles Gardner Hospital in 2018. He is currently a pulmonologist and internal medicine consultant at Hospital Tuanku Jaafar, Seremban. He has presented multiple posters and was also a principal investigator for the assessment of asthma control level at the tertiary center, ESCOR trial, and he is currently also a guest lecturer for the medical students in UCSI University. So without further ado, Dr. Raymond, I'll pass the floor to you.
Thank you so much, Dr. Vidya, for your kind introduction. Okay. It gives me a great privilege to introduce my fellow colleague, Dr. Hema Yamini, fondly known as Dr. Hema lah. All right. So she graduated from Malacca Manipal in 2008 and got her membership in 2013. So the relevance with me is that Dr. Hema and we went to the same hospital in Perth and we did our attachment there. She did in lung cancer and interventional pulmonology, right? And then in addition to that, she completed a 3-month training in IP, interventional pulmonology, at Nagoya Medical Center in Japan. She's currently the consultant pulmonologist and head of Department of Interventional Pulmonology at Queen Elizabeth Hospital, Kota Kinabalu. She's published numerous research papers in peer-reviewed journals and also in the field of interventional pulmonology, right? So she's gonna speak to us regarding her love of her life, that is interventional pulmonology, and she'll enlighten us about biopsy approaches in lung cancer. Thank you very much, Dr. Hema, for joining us, and I hope whatever you're going to share with us will be very, very useful to all of us. All right. Thank you. So the floor is all yours.
Thank you. Thank you so much, Dr. Raymond, for the kind introduction. Actually, Dr. Raymond was one of the doctors who inspired me to do respiratory medicine because we used to work together in Seremban last time. Okay, so my topic today will be on biopsy approaches in lung cancer. So before we start, let's just think in your daily clinic. Okay, if you have a 63-year-old man who's coming to you with cough, and then when you do a chest X-ray, you see a mass at the right upper lobe, and then you see some effusion. So what do you do next? Okay, do you want to biopsy the mass first, or do you want to drain out the fluid? or should you do a CT scan? So basically, by the end of the talk, I hope that I can make things clear as to where to start when you see somebody with a suspected lung cancer. Okay, so this is the content of my talk. Which route is best to diagnose and stage, and what do we mean by best? Number 2 is tools that we use in diagnosis and staging of lung cancer, and approach on deciding the site of biopsy and how we do it. So this chart is reproduced from the 3rd edition of the ACCP Guidelines on Diagnosis and Management of Lung Cancer. It basically gives us an overview of the initial evaluation and workup of patients with suspected non-small cell lung cancer. And you can see that today we are mainly going to concentrate on confirming clinical stage and clinical diagnosis in terms of biopsy. So when we see which route is best to diagnose lung cancer, to stage lung cancer, as well as to obtain sufficient tissue for all the immunohistochemical staining, as well as molecular studies to guide targeted therapy, when we say best, we are talking about the safest route, least invasive route, and a route that gives us a high diagnostic yield. Okay, so where to biopsy now? So first thing, 2 questions to ask is, where is the primary lesion? That's the first one. And what is the presumed stage based on imaging? Okay, before we decide where to biopsy, these are the 2 things we look at. Look for where is the primary lesion and what is the presumed stage. And what can help us is our imaging modalities such as CT scan, PET scan, MRI, and so on. So for an accurate staging to be done, we need a uniform and validated staging system. The TNM staging, which stands for tumor node metastasis, is an internationally accepted system used to characterize the extent of the lung cancer. Okay, so the latest one that we're using now is the 9th edition, which was released in January this year. And this TNM staging is issued by the International Association for Study of Lung Cancer. So this is basically the document, and this, if we divide it into T and M, T means tumor staging. T is determined by the size of the primary tumor. So we got T1, T2, T3, T4, and it depends on the size of the tumor as well as the involvement with the adjacent structures. For an example, if a tumor is more than 7 cm, or if the tumor has already invaded the diaphragm, then we can say that this is a T4 tumor. So it depends on the size as well as the involvement with the surrounding structures. The next component is the N staging or the nodal staging. This is determined by where the location of the lymph node in relationship to the primary tumor. So we have got N0, N1, N2, N3. So just for an example, I hope you can see this. So you can see N stages of the right-sided tumor. So if you see the right side, there's a tumor there. And then if there is an ipsilateral hilar node or a peribronchial node, the green nodes, then this is a N1 disease. But if the yellow nodes are involved, ipsilateral, paratracheal, subcarinal node, then this is a N2 disease. And when the nodes on the opposite side, the contralateral to the tumor side is involved, then this becomes a N3 disease. So basically, this is how we do nodal staging. Next is M, which denotes metastasis. This is based on the presence of metastasis, their location, and the multiplicity. So like in M1A, for an example, so if there is a pleural effusion, or if there's a pericardial effusion, or if you see if the tumor is on the right side and suddenly you see a nodule on the left side, then this is considered an M1A. All right. If you have a single extra-thoracic metastasis, example, the patient has a single liver lesion, then this is known as M1B. And when you have multiple extra-thoracic metastasis in a single organ, that means if you see multiple spots on the liver, then this is M1C1. And then we have M1C2, where you have mets to different organs as well, like the adrenals, brain, and all that. So this is the staging system we use for lung cancer. So now, based on this staging system, once we looked at the CT scan and we know already that, okay, this is most likely going to be this stage, then we need to target the most advanced site of disease first when we biopsy the patient. Okay, so just imagine like the patient that I mentioned to you all just now. If at all I were to just go for the upper lobe lesion and not the pleural effusion, then I will not know whether the pleural effusion is actually part of the lung cancer, and I'll downstage the patient. But if I were to take the pleural fluid or do a pleural biopsy, then if that is involved, then we know this is already a stage 4 disease. So always we need to target the advanced site of the disease first. But when there is overwhelming imaging evidence of distant mets, it means your patient has got, you can see bone mets, brain mets, liver mets, then you would want to target the most accessible site. Right? So tools used in the diagnosis and staging. So if you see, sorry, there's a lag, imaging techniques. So first, we need imaging modalities to see where the primary tumor is. So you can use a chest X-ray, CT, PET-CT, MRI, or an ultrasound. Then we go to endoscopy techniques. When you talk about endoscopy techniques, we're talking about a flexible bronchoscopy, fluoroscopy, endoscopic ultrasound, endobronchial ultrasound. And then we go to image-guided techniques, such as CT-guided biopsy or CT-guided FNA, ultrasound-guided biopsy or FNA, as well as the simple pleural tap. Then minimally invasive surgical techniques. When you can't do non-invasive methods, then you might have to go for surgical techniques such as Barrett's biopsy, mediastinoscopy, and others. So always remember that the diagnostic and staging approach must be tailored to the individual patient according to the risk-benefit, what patient prefers, and what is available, the resources available at your center. So approach on deciding the site of biopsy, how we do it. So the first thing, I always say we need to target the most advanced site first, right? So the first thing to ask is this a stage 4 disease? Is there an extra-thoracic metastasis? So if there is an extra-thoracic metastasis, then we would probably biopsy the extra-thoracic metastasis first. Okay, this will diagnose as well as confirm. So if you take a biopsy from a liver biopsy, a simple liver biopsy, ultrasound-guided liver biopsy, it shows a metastatic adenocarcinoma, then you already know that this is a stage 4 disease. But in some cases, the metastatic site may be in a difficult location to biopsy, or it will be too invasive, example, a brain mets or something. So then you need to, if it's difficult, then you need to find the easiest method, the most direct way to biopsy, if the metastatic site is difficult to biopsy. Okay, so now if your patient doesn't have an extra-thoracic metastasis, what to do next? Okay, the next question to ask is there a pleural effusion or a pleural nodule? So if there is a pleural effusion, okay, or a pleural nodule, if there's a pleural effusion, what do we do? If there is an effusion, we just, this is the BTS guidelines. So if there is an effusion, we need to find out what is the cause of the effusion. Is it related to the malignancy? So a simple ultrasound-guided pleural tap will give you some idea. All right, you send it for your normal pleural fluid analysis, see if it's exudative, and then send it for cytology. If the pleural fluid cytology is negative, does this mean that your patient does not have lung cancer? So this is a systematic review and meta-analysis, which was published in Thorax in 2022. And you can see that they have included 36 studies with 6,057 patients. And the overall diagnostic sensitivity of pleural fluid cytology was only 58.2%. So this tells us that pleural fluid cytology is not enough. I mean, if it's negative, it does not mean for sure that your patient does not have cancer. So if you see a patient with pleural effusion and a lung mass, right, you cannot just think that, oh, this must be due to cancer, because it might be because of an infection. And if your cytology is negative, you still need to investigate further. So what can we do if the pleural fluid cytology is negative? Okay, these are the 4 methods that are used: a blind or closed percutaneous needle biopsy, image-guided needle biopsy, fluoroscopy, and video-assisted thoracoscopic biopsy. Okay. So closed pleural biopsy, or also known as Abrams biopsy, where they use Abrams needle. It's used those days. Now we don't really use it that much. Okay, so the thing is that the diagnostic yield for malignancy is only 57% because it's sort of a blind procedure. It's not real time. And most of the time, the metastatic deposits in the pleura are randomly distributed. So since you're not doing it under real time, you're not sure where you're hitting when you take the biopsy. And also the metastatic deposits are usually close to the costophrenic angle near the diaphragm. And this is an area which we usually avoid when we do a closed pleural biopsy. Okay, so CT-guided biopsy, I'm sure many of you are familiar with it. Pleural thickening or pleural nodules can be approached through CT-guided biopsy. If you can see the pictures, you can see this is a pleural thickening in the second picture. And under CT guidance, this is approached. Pleuroscopy is commonly done by pulmonologists. This is a procedure performed to examine the pleura and obtain biopsies from the parietal pleura, and this is done under direct vision by introducing an endoscope into the pleural cavity. Okay, so by doing pleuroscopy, we can actually examine the pleural cavity using the pleuroscope, and we can take multiple biopsies from the parietal pleura and target the abnormal areas. And the specimens are then sent for histopathological examination. Okay, so, sorry. Okay, so this is like once we enter into the pleural cavity, so you can see the collapsed lung, and then skipping a bit. Yeah, so the parietal pleura, if you see this part of the chest wall, is filled with all this whitish nodule, whitish plaques, okay, over here. So you know this is abnormal. This is how it looks when we do pleuroscopy. This is the posterior chest wall, okay? And you can see the diaphragm here. This is the costophrenic angle, okay? Then when we identify an abnormal area, a forceps is used to biopsy the parietal pleura, right? And you can see this is called the grab and tear method. Okay, so this is the parietal pleura and this is sent for HPE. Okay, how about when the pleural effusion is very small? Because for us to do a pleuroscopy, we most of the time need sufficient amount of fluid to dissect in and go in. But sometimes the pleural space is very small. There is a small collection, and if we were to do pleuroscopy, there is a risk of visceral or diaphragmatic damage. And in those cases, we can do induction of artificial pneumothorax. So how do we do this is because there is negative pressure within the pleural cavity. When we create an open connection to the atmosphere, what is going to happen is there is going to, the lung is going to fall away from the internal chest wall, and then it creates a space, and that space can be dissected into during pleuroscopy. Okay, so how do we do this is by inserting a white bore needle under ultrasound guidance. But it's very important to ensure that there is sliding sign on ultrasound, because sometimes when we go in for pleuroscopy, we see some parts of the lung is adhered to the chest wall. So to ensure that we don't, when we insert the needle, we are not going to insert it into the lung, you must make sure that there's sliding sign on ultrasound. So these are various needles that can be used to induce artificial pneumothorax. So you see the one here, this is known as butene trocar needle, and the one on my right is the varus insufflator needle. Okay. So in Queen Elizabeth Hospital, we use the varus needle for pneumothorax induction. If you can see this picture here, sorry. Okay, the lung mass is left lung mass, which is difficult to reach through bronchoscopy or even CT-guided biopsy. And you can see a small little effusion here. So this is a 63-year-old lady with this lung mass. So pre-procedure, we ensure that there is proper sliding on ultrasound. Sorry, there's some lag on my video. So there's proper sliding on, you can see the proper sliding sign here. And then once the needle is inserted, okay, once the pneumothorax is induced, here you see that there's a difference. There's no sliding sign anymore. And then you can see the pleural space is really small, but all these whitish nodules are seen, and the biopsy is taken from these nodules, and the results came back as metastatic adenocarcinoma. Okay, So what if our patient does not have an extra-thoracic metastasis? There's no pleural effusion. Next question to ask is there a nodal disease? Okay, are the nodes, lymph nodes enlarged? So ACCP guidelines for staging of non-small cell lung cancer recommends endobronchial ultrasound or endoscopic ultrasound, EBUS or EUS, as the first modality of choice for invasive mediastinal staging. So if you look at this, this is an EBUS. So it's almost like a flexible bronchoscope, but the end of the scope, there is this ultrasound probe. This ultrasound probe, it's a convex transducer, the frequency about 7.5 megahertz. And this allows real-time sampling of the mediastinal and hilar lesion. It's minimally invasive and a very safe procedure. The diagnostic yield is also quite good. The sensitivity of this procedure is 93% and specificity is 100% for lung cancer. So EUSB is basically using the same scope and going through esophagus to ensure that all the nodes are able to be accessed, because some nodes you can access through EBUS, some you can only access through EUS. So these, when you combine these two methods, you are able to do a complete evaluation of the mediastinum. So let me just take you quickly through the first case. This patient is a 64-year-old lady who presented to us with chronic cough, loss of weight, loss of appetite for 8 months. She's known to have hypertension and she has been on antihypertensive for the past 4 years. She's a non-smoker. Chest X-ray showed a large left lung mass. So we went on to do a CT scan and this showed a hilar mass measuring about 9.7 times 9.6 centimeters with some enlarged mediastinal nodes. So here you can see the lung mass here. This is the left hilar mass. Over here you can see the subcarinal lymph node. And here you can see the enlarged paratracheal lymph node. So if we want to target the most advanced site first, we should target this node, because if this contralateral node is involved, then this is an N3 disease. But if this contralateral node is negative, then we check for the subcarinal node. If this is positive, then it's a N2 disease. Okay, so that's when we do a linear EBUS procedure. So you can see the EBUS is usually advanced through LMA, and then we identify the enlarged lymph node. So you can see this is the station 7 node. The needle is then introduced through the working channel, and then you can see the TBNA needle within the 4R node. Okay, so then we are very lucky in Queen because we have pathologists, on-site pathologists. We do rapid on-site evaluation. They will confirm the adequacy of the material, and this patient's final pathology revealed adenocarcinoma. So she had stage 3C because the 4R node was positive. So it's T4N3M0, and she was referred to the oncologist for further treatment. So EBUS TBNA is very safe. It's minimally invasive, but sometimes, because now due to the evolving landscape of the lung cancer treatment, we have immunotherapy, we have targeted therapy. So we need larger tissue samples for all these molecular studies. Sometimes the samples that we get from the TBNA may not be enough for all these molecular studies. And also we realize that in cases of lymphoma or even benign cases, the cytology samples are not enough. So then comes something we call EBUS transbronchial nodal cryobiopsy. So what happens is this thing here is called a cryoprobe, all right? So it uses a gas called nitrous oxide, and it causes freezing of the tissue. So what we do is we at the same area where we make a puncture with the TBNA needle, we insert the 1.1 millimeter cryoprobe into the tract, and then we confirm the position under real-time visualization using EBUS, and then it is activated for 3 to 10 seconds to freeze the tissue within the node, and then it is removed. So you can see this is a station 7 node, 1.1 millimeter cryoprobe is within the node. It's activated for 5 seconds, and then the entire scope together with the cryo is removed. So this is the samples. So this is quite large compared to TBNA samples. Right? So now if your patient doesn't have the extra-thoracic metastasis, there is no pleural effusion, and then so what is the next thing to do? Nodal disease, there's no nodes that are enlarged. So now we need to think of biopsying the primary lesion, okay? So by how to do the biopsy of primary lesion, we go back to where is the lesion? Is this a central region or is it located in the peripheral part of the lung? All right, so centrally located lesion, they usually present as hilar mass, right, or a collapsed consolidation. And then in these kind of cases, when it's central, most of the time we are able to approach it through bronchoscopy techniques, flexible or rigid bronchoscopy. Then we do things like biopsies, washing. So you can see how it looks like an endoluminal lesion. Okay, so here you can see endobronchial lesion, so you can biopsy this lesion. Here you can see that there is a tumor behind which is causing irregular mucosa. Sometimes you biopsy this, you may be able to get an answer, all right? So biopsy can be done using forceps, but sometimes when the tissue is very necrotic, then we go ahead and do the cryobiopsy where we get deeper, we freeze deeper samples. Right? For peripheral lesions are usually located in the peripheral 2/3 of the lung. And these lesions, we're not able to directly see using our flexible bronchoscope because they are usually distal to the lobar and segmental bronchus, which we can access during flexible bronchoscope. So these are examples of peripheral lesions. Okay, so you can see this is a peripheral lesion, right? Which we are not able to approach using bronchoscopy because our bronchoscopy usually just stops over here. So what can we do in these kind of cases? So transthoracic needle biopsy or your CT-guided, ultrasound-guided biopsy. So under CT or ultrasound-guided needle is a core biopsy needle is inserted through the chest wall. And the sensitivities of this is about 74 to 90%. Okay, so you can see over here how it's done. The needle is going in through the lesion. Okay, but the complication is quite high because complication of pneumothorax is around 10 to 15%, especially in patients who have got emphysema, bullous disease, or chronic respiratory failure. A lot of our patients with lung cancer actually have emphysema as well. So the risk of pneumothorax is quite high because you need to traverse the pleural space and some parts of the lung tissue, right? So role of bronchoscopy in peripheral lesions. So radial EBUS, just now we spoke about linear EBUS. Radial EBUS is another equipment. It's a thin, flexible ultrasound probe, and it has got a 360-degree view radiating outward. This allows real-time localization of lesions distal to the physical reach of the bronchoscope. So let me just show you a short animation video by Olympus just to introduce the concept. Okay, sorry, it's skipping, I think. So you can see the bronchoscopy going in. Okay. So the tumor is beyond the reach of the bronchoscope. So what we do is we use this probe, okay, to try to identify the lesion, okay, together with a guide sheet. So if you see over here, when the lesion is identified by the probe, you can see that ultrasound image changes. And then once you're happy with the area, then you leave the guide sheet and put in your biopsy instruments. Can be a forceps, can be a brush or a cryo probe to biopsy that lesion. So these are a few of, we do in Queen, we also do it under fluoroscopy guidance. So these are a few of the images of the cases we've done. And you can see that the bronchoscopy stops here. That's why we can't directly reach this lesion. So over here and over here. And this is the image you see when the probe is within a mass, right? So there are also other bronchoscopic modalities to reach the periphery of the lung. Okay, we have ultra-thin bronchoscopes now. The bronchoscope diameter is only about 3.1 as compared to 3.1 millimeter as compared to the conventional ones, which are around 5.8 or 5.2 right? So if you can see, this is the regular bronchoscope, which can only reach here, but if you have ultra thin, it can reach even more distally, right? So third or fourth generation airways. We also have a lot of these very advanced techniques to ensure that there is the lesions, even peripheral lesions can be done accurately, like virtual bronchoscopic navigation is basically like a Google map or Waze, which shows you how to reach your lesion. Okay, then we have got electromagnetic navigational bronchoscopy, as well as cone beam CT assisted bronchoscopy. These are all very advanced techniques. They also have robotic bronchoscopy now. So I've come to the end of my presentation. So these are the take-home messages that I would like to present. Diagnosis and staging of lung cancer should ideally be performed in a single procedure. You don't want to do multiple procedures. And staging and diagnosis will be most efficient if we target the most advanced site. So you don't have to do multiple procedures, right? Then the diagnostic and staging approach should also be tailored to the individual patient, depending on the risk, benefit, what the patient prefers, what the family prefers, and what is available at your center. Okay, larger and intact tissue samples are needed for molecular and ancillary tests. When in doubt, always bring to lung cancer MDT meeting. All right. Thank you very much. I'm happy to take any questions.
Thank you very much, Dr. Hema.
Thank you.
May I know if there's any questions? Okay, can I start some questions, Dr. Hema?
Yeah,
Right. Okay. So I just want to ask you, how long do you think it will take for
Sorry?
us? How long will it take for a patient to present with an abnormal chest X-ray to getting the diagnosis correct and then referral to an oncologist, for example?
Okay. So
Ideally, yeah.
ideally, yeah. As soon as an abnormal chest X-ray, like for us, I just share my experience in Sabah. So if the clinic kesihatan or district hospital, if they come across a patient with an abnormal X-ray, then we will ask them to get an urgent CT scan. So sometimes there is a waiting time for CT scan, but usually in Sabah, it's about 2 to 3 weeks, especially if a pulmonologist has said that it's urgent. So after that, for us, depends on what is the mode of biopsy. Usually it's about another 2 weeks for us to do a scope, EBUS or something like that, takes about 2 weeks. And then after that, the results takes another 2 weeks, and then we refer on to oncologists. So roughly the whole process is about 2 months, Dr. Raymond. Yeah.
Okay, yeah. So I think it's roughly around 6 to about 8 weeks at my center as well. Of course, preferably it should be lesser,
Yeah.
because the lung cancers, we don't know. Some of them, they behave very aggressively, and some they don't. Right? Probably you can also tell us a little bit about the characteristics of lung nodule, which shows very high suspicion whether it's malignancy or otherwise. Especially, in our places and our centers and all that, the incidence of non-malignant nodules are pretty much high as well. So, what would be the red flag signs if we see a nodule in your CT, and which should prompt you for starting your investigation?
Okay. Women. Most of the time, there is a Brock's nodule criteria that we use. So basically, if patients who are smokers, clinically patients who are smokers, family history of malignancy, and on top of that, the nodules are in the upper lobe, it's spiculated, and the size of the nodule as well, we can just put all this into the calculator, and then identify the risk. But saying that, in what we do is, most of the time, I think the thing that we are most concerned about is it TB or malignancy, because both may have these upper lobe lung lesions. So we do the TB workup first, and if TB workup is negative, then we'll ask for a CT scan. And if the CT scan is concerning for a malignancy, then we will immediately do a biopsy.
Okay. So, yeah. uh, uh, has there been a stage where there will be a wait and watch approach to these lung nodules, and even if you need to wait, how long do you think will be safe to wait for this kind of condition?
Okay. So, of course, patient preference as well, and whether they would want to, are able to, come back and check again in 3 months. Usually, if it's a lung nodule and it's suspicious lung nodule, I will always go back to the Brock's not criteria and see what is recommended. But most of the time, if it's just a nodule and I'm not worried, then I'm not so worried, then it will be 3 months. But if it's something which is not just a nodule and patient does not want to do, I'll ask them to come back earlier, maybe in 6 weeks with another repeat CT.
So I guess some of them they can use the lung rats and as well as the Fechner Society's criteria.
Yeah.
You can decide whether how soon, whether it's a low risk or high risk category, and of course whether it's a semi-solid or solid, speculated as how you put in to further classify these lung nodules, and then to act on whether it's have to do it immediately or that we can wait between 3 to 6 months or as such, right?
Yeah.
Okay. I just want to inquire regarding a newer trend called liquid biopsy. Yeah, right. Probably if you have any idea or experience with that, probably you can share with us, Dr. Him.
Yeah. So liquid biopsy, usually in patients in whom those patients who we have sent so far is the patients in whom they're not fit for any form of biopsy. They're ill, and we are hoping that this is an adenocarcinoma, and we can give them some treatment quickly. So those kind of patients who are not fit for biopsy, clinically not fit, usually then we will discuss with the oncologist for liquid biopsy. So liquid biopsy for lung cancer, it can be sent, usually they send it through blood. It's quite expensive because you can't do it under government setting. So we send it to a private lab, and usually we're looking for type of cancer, meaning that if it's adenocarcinoma, and also sometimes we look for the mutation that is present. So, but even though it is validated, the sensitivity and specificity, I'm not so sure. I don't think it is as good as getting a biopsy, a tissue biopsy. So usually we reserve this liquid biopsy only in cases where it's difficult for us to obtain a biopsy.
All right. Thanks, Dr. Hema. I've got a question from viewers. It's from Dr. Lim Eng Sang. So he's asking about what would be the size of the pleural nodules considered a warning sign and should undergo an intervention? Size of the pleural nodule.
Size of the pleural nodule.
Yeah.
Okay. So pleural nodules, actually, any form of pleural nodule is not normal. It's not something which is normal. So if it's something that we can biopsy, then I think we should go ahead and biopsy it. Meaning anything which is 1 cm or more, we should biopsy it. But if we can't biopsy, either one, and you don't see any other primary tumors anywhere, either we can proceed with a PET scan to see whether is this benign or malignant, or you can repeat another CT in about 3 months' time. to see whether it's growing and it is now safe enough for you to biopsy the pleural nodule. And of course, all this is in context with the clinical assessment as well, the patient.
Thank you for the answer. Okay. Um, okay. So may I ask regarding uh, in what cases would you want to rebiopsy uh, a nodule or a mass?
Okay. So some of the cases that, okay, first thing is that sometimes we biopsy the patient, and then when the results comes back, we don't have enough for tissue for the full molecular studies, or that's when we have to rebiopsy. Number two is patient is already on treatment with some targeted therapy or chemotherapy, or even if the patient has undergone surgery and now has a recurrence. And then we go into biopsy to look for any mutation that we can target after we have treated the patient initially. So for recurrence, as well as if we don't have adequate tissue to work with in the beginning.
Okay. Yep. That's lovely. All right. Is ENB is available at your center, electromagnetic navigational bronchoscopy?
Unfortunately not. We still do manual mapping.
Okay, all right. So I was just wondering whether you have any experience between these two big brands, Super Dimension and Viren, and which one would you prefer to use ENB?
So the Super Dimension, Super D, I have had I've used it before, and that's basically like you feed the CT scan into the system, and then it takes you through like a Google map to show you exactly where to go. But the other big, the Veran, you can actually see the tool within the lesion, if I'm not mistaken. Yeah. So the thing is that how we do radial EBUS peripheral is when peripheral nodule is we actually map it based on the CT, and so far we find it to be quite accurate, and it is affordable also because we just use manual mapping. Yeah.
All right. Is there any other questions? Any burning questions, right, that you want to ask Dr. Hema? This would be your opportunity. Yeah. Is that your team?
Yes, please come to Sabah.
Yeah. Right.
Okay, I think there
Okay.
are no more questions from the floor. So I think that will be the end of our session. Thank you so much for your very comprehensive lecture, Dr. Hema, and thanks, Dr. Raymond, for your time and valuable input. So thanks everybody for joining, and join us again next week for another interesting topic in respiratory medicine, which is central airway obstruction. Thank you and have a great weekend.
Thank
Thank you very
you.
much. Thank you so much, Emma. Thank you.
Thanks, Dr. Ruben.
Bye.